Welcome to our cardiovascular case study, presented by Dora, Hannah, John, Karina, and Michelle. Our client is a 54-year-old man who is a Wall Street stockbroker and the primary financial provider for his 2 teenage children and soon-to-be wife. He enjoys spending time with his family, playing golf, and cooking. He comes into the emergency department experiencing shortness of breath, irregular heart rhythm, which he's had for the last 4 days, and fatigue. He also has swelling in his legs and decreased libido. He was previously diagnosed with diabetes, high blood pressure, and is obese. His family has a history of high blood pressure, and he used to smoke 15 cigarettes a day but has recently quit. After admission, he is found to have tachycardia, a BNP of 899, and his left ventricular ejection fraction is calculated at 15%. What disease do you think this is? He has been diagnosed with dilated cardiomyopathy.
Anatomy and functions of a normal heart. The heart is a muscle that pumps blood to supply oxygen and nutrients to the tissues throughout the body. In doing so, it removes carbon dioxide and other waste. There are 2 upper chambers, each called atrium. The atria collect blood as it flows into the heart. The 2 lower chambers, called ventricles, pump blood out of the heart to the lungs or the other parts of the body. The left ventricle pumps oxygen-rich blood to the rest of the body, so it is thicker and it creates what is our blood pressure. The heart also has one-way valves to prevent the backflow of blood. Healthy valves open and close in exact coordination with the pumping action of the heart's atria and ventricles. There are 2 semilunar valves called aortic and pulmonary, 2 atrioventricular valves called tricuspid and mitral. There are coronary arteries that run along the surface of this muscle and provides oxygen-rich blood to the heart. Anatomy and functions of an affected heart. Dilated cardiomyopathy is clinically characterized as left ventricular or biventricular dilation and impaired contraction. It is a disease in which the ventricles are abnormally enlarged, thickened, and/or stiffened. The affected heart's ability to pump blood is weakened and affects contractility. As a result, there is a decrease in the blood volume pumped at each contraction, known as stroke volume, and therefore decreases cardiac output or the amount of blood pumped by the heart per minute.
Now that we've discussed some of the anatomy of dilated cardiomyopathy, let's dive into the pathophysiology. So the most common type of heart failure is dilated cardiomyopathy, which is a morphological phenotype of cardiomyopathy. Dilated cardiomyopathy is more common in males and can occur at any age. It occurs progressively and can lead to decompensated heart failure. In developed countries, it is a common reason for needing a heart transplant. New sarcomeres are added in series and the chambers of the heart grow larger. However, the myocardium itself is a lot thinner compared to the new size of the chambers. In the image on the slide, we can see that the myocytes have stretched and are abnormally enlarged. The nuclei are also bigger than normal. This leads to weakened contractions, and the stroke volume is therefore decreased. As a result, there are pathological mechanisms that are affected. These may include neurohormonal activation of noradrenaline, renin-angiotensin aldosterone, and vasopressin, as well as hyperactivity of the HPA axis, which leads to an increased release of cortisol into the bloodstream. The stretching of the myocardium also impacts the tricuspid and mitral valves, where they cannot close as well, and this can lead to regurgitation or backflow of the blood into the atria. In summary, a hallmark pathophysiological feature of dilated cardiomyopathy is systolic dysfunction of the left or both ventricles. Right side heart dysfunction is almost always caused by the left side. Reduced sarcomere contractility increases ventricular volumes to maintain cardiac output through the Frank-Starling mechanism, providing the thin-walled dilated left ventricle appearance that is usually observed in dilated cardiomyopathy. In 20 to 48% of cases, dilated cardiomyopathy can be caused by an inherent problem of the myocardium. Gene defects affecting structural elements in the cardiac muscle cells, which are called cardiomyocytes, ion channels, cytoskeleton, and mitochondria have been identified. However, it is important to note that most cases are considered idiopathic. In the US, alcohol overuse contributes to 21 to 36% of cases because alcohol and its metabolites can be toxic to the myocytes. Cardiomyopathies were previously divided into primary and secondary cases. A primary cardiomyopathy was confined to the cardiac muscle, while secondary cardiomyopathy was part of a systemic disorder affecting multiple organs such as inflammation, malnutrition, and infectious, autoimmune, or endocrine diseases. Today, new and more appropriate classifications are used. There are 4 stages. Patients who are at high risk of cardiomyopathy but do not have structural heart disease or symptoms of heart failure are not present would be considered stage A. Stage B, structural change has developed but symptoms of heart failure are not present. In stage C, we can see structural heart changes with the development of symptoms of heart failure. And lastly, stage D, refractory heart failure, which is present with repeated symptoms of heart failure at rest and occurs even after intervention. Further medical therapies are required, and in some cases, patients cannot be safely discharged from hospice. Cardiomyopathies can be further subdivided according to the underlying conditions.
For signs and symptoms of cardiomyopathy, which will include fatigue, shortness of breath, which is called dyspnea, when you're active or lying down, reduced ability to exercise, swelling in your legs, ankles, and feet, swelling in your abdomen due to fluid buildup, chest pain, and extra or unusual sounds heard when your heart beats. For diagnosis, the doctor will order a blood test, which will reveal if you have an infection, a metabolic disorder, or toxins in your blood that can cause dilated myopathy. A chest x-ray to check if your heart and lungs changes or any abnormalities of your heart structure and size, and also for fluid in and around your lungs. He will order an ECG, which is electrocardiogram, which records electrical signals as they travel through your heart. Your doctor will look for patterns that may be a sign for abnormal heart rhythm or problems with your left ventricle. He will order an endocardiogram, which is a primary tool for diagnosing dilated cardiomyopathy, which uses sound waves to produce images of the heart. This test will also reveal how much blood is being ejected from your heart with each beat and whether your blood is flowing in the right direction. He will order an exercise stress test, which will have electrodes attached to the patient during his test to help and measure your heart rate and oxygen use. This type of test will show the severity of problems caused by dilated myopathy. If he's unable to exercise, he may be given medication to create stress on your heart. In some situations, he might order a CT or MRI scan to test to check the size of the heart and function of the pumping chambers. Because our patient suffers from depression, this has been linked to low-grade inflammation, which is involved with clotting the arteries and rupture of cholesterol-filled plaque. Depression also boosts the production of stress hormones, which will dull the response of the heart and arteries to demand for increased blood flow. This activates blood cell fragments, known as platelets, making them more likely to clump and form clots in the bloodstream. For medical treatment, the doctor might order ACE inhibitors, which is angiotensin-converting enzymes, which are used to widen and dilate blood vessels to lower blood pressure and decrease heart's workload. He might order angiotensin II receptor blockers, which are possible alternatives for people who can't tolerate ACE inhibitors. He might order beta blockers, which slows the heart rate, reduces blood pressure, and may prevent harmful effects of stress hormones. This may reduce signs and symptoms of heart failure and improve heart function. He might order diuretics, which removes excess fluid and salt from the body. This will decrease fluid in the lungs to breathe easily. And lastly, he might order antidepressant medication such as Zoloft or Celexa, which have been best studied and effective for patients with heart disease.
Due to this diagnosis, our client has experienced dramatic life changes. He has limited mobility and struggles with his physical functioning. He often feels fatigue and had to reduce down to part-time work, which puts a strain on his family's finances and requires cutting back of expenses or for his partner to get a better paying job. He doesn't have enough energy to play golf, which means he gets less exercise as well as misses out on social participation with his golfer friends. Our client is told his diagnosis in the hospital with his partner present. This caused him anxiety for his own condition as well as worrying about how his partner would take it. He also has anxiety because there was a delay after discharge and seeing the cardiologist. He is most worried when he's told he might need a heart transplant or a pacemaker and worries about his longevity, wondering if he will live through his 60s. He is also experiencing depression and feels he is living in fear because of his disease. He's worried about how his children will take the diagnosis and worries about the anxiety levels as well. His partner has taken over as his caretaker, and he's concerned about being a burden to her. She helps him with everyday life things that he now struggles with, such as ADLs, like bathing, grooming, and mobility, and IADLs, such as cooking, shopping, and housekeeping. He also needs assistance in his health management, such as with his new dietary restrictions, medication management, monitoring his symptoms, and getting to his medical appointments. Studies have found that anxiety and adaptation to a new diagnosis of heart failure can often be too difficult to accept and can impact the patient's behavior or even lead to depression, like in our client's case. Heart disease patients who experience anxiety have twice the risk of dying, and those who experience both anxiety and depression have the triple risk of dying. These struggles with his mental health exacerbates his sleep issues.
The progression of disease on occupations can lead to depression, stress, and anxiety without addressing the activities that are meaningful to him and his independence to perform his activities of daily life, which can also lead to part-time as a stockbroker, and that can equal a decline in a fulfilling life. Some interventions for occupation can be energy conservation. Due to lack of sleep, it would be important to do energy conservation and deciding which occupations are worth more in the day. It is also important to be mindful and to do a cognitive behavioral therapy in which focuses on how a person's thoughts and feelings affect their behavior. And it would be good to do couples therapy with this new change and role that the wife has as a caretaker, as well as doing individual therapy because this diagnosis can lead to depression and can cause it. With these interventions, he can better manage going to work, spending time with the family, cooking, and playing golf. Interventions with activities of daily living could be including a shower chair, and for cooking, it could have pre-cut or frozen produce, kitchen appliances, for example, food processor, and raised toilet seat, in which all of these interventions can help with energy conservation. What is something that you learned about dilated cardiomyopathy? Thank you for listening.